buenas noches a todos, bienvenidos de nuevo a una nueva sesión del Diplomado Internacional en Neurología Veterinaria. Recuerden que la clase de hoy va a ser en inglés, así que como siempre, si le quieren escuchar en español, tienen que cambiar la interpretación a español. Continuamos hoy con el séptimo módulo. Vamos a tener el honor de presentar al doctor Marios Jarolombus, que nos va a estar hablando sobre el tratamiento del paciente epiléptico. El doctor Marius es especialista en neurología veterinaria, reconocido por la ABBS estadounidense y la EBBS europea. Tras completar sus prácticas en pequeños animales en el Queen's Veterinary School Hospital de la Universidad de Cambridge, trabajó en práctica privada general y de urgencias en el Reino Unido. Durante este tiempo también completó un diploma de posgrado en neuroimagen avanzada en el Instituto de Neurología del University College de London. Realizó su formación inicial en la Universidad de Cornell antes de incorporarse a la Universidad de Ghent de Bélgica, para completar su residencia en neurología aprobada por ACVIM y por la SBN. Tras aprobar sus credenciales y los exámenes de cada colegio por separado, se convirtió en diplomado del Colegio Americano de Medicina Interna Veterinaria y el Colegio Europeo de Neurología Veterinaria. Ha participado en múltiples programas de formación y cursos impartidos por universidades del Reino Unido y Estados Unidos. También ha sido reconocido como Chartered Scientist por el Science Council del Reino Unido y como Fellow of the Higher Education Academy. Por último, ha sido representante de la Sociedad Europea de Neurología Veterinaria. Dr. Marius, welcome.
Hello, everybody. Thank you for this amazing introduction. I really like the video on the beginning. Really high tech.
Okay.
Indeed, I can start sharing my screen, or
Yes, you can share your screen and the auditory is all yours.
Thank you so much. So we will discuss about the treatment of epilepsy, but also I want to give some general information first before starting talking about treatment. So it is better for you to understand the rationale. So I would like to start with with a few videos. This is a very typical generalized tonic-clonic epileptic seizure. You can see that the dog is not aware of the environment, that is losing urine and saliva, and it has these tonic-clonic movements on all the limbs. You see these spasms, and after the main stage, the dog will start recovering and will be disoriented and confused. So this is another video from a cat. In cats, epilepsy can seem a little bit different. Usually, most of the cats can, with generalized seizures, can show some degree of delirium, like hyperexcitability, aggression, running around, as you can see. And then they fall, they collapse, and they start having tonic-clonic movements, as you can see from the video, like severe. This is a severe form of generalized seizure. So the cat, like in a dog, is not aware of the environment, and as you can see, has collapsed and now having these tonic-clonic movements, the contractions on the face, and losing also saliva. So this is also very typical generalized seizure in cats. Here I would like to show a horse with generalized seizure. You can see that the horse is in a confusion state. It has this spasm, that these muscle contractions that lead to abnormal movements of the neck and the head. And like dogs and cats, the horse also is collapsing and is showing some clonic movements. And of course, is confused, is not really aware of the environment during the event. Now he's trying to recover, and you can see that he's in delirium state and He has some minor contractions on the face, as you can see. This is another video of another horse. This is focal seizure. Like you can see these focal muscle contractions affecting mainly the head, neck, and the front limbs. They look like tremors, but they are more like focal seizure. Also, the horse is not. It has altered consciousness, so it's not totally aware of the environment, as you can see. So this is kind of a focal seizure in a horse. Now I would like to show you a last video. What I want you to observe here is that the dog has these weird contractions like flexion of the hind limbs. This is the main motor activity that the dog manifests without any other tonic-clonic movements, without the dog collapsing, and especially the dog is aware of the environment. It has not lost consciousness. So you see, this is different from the previous episodes, from epilepsy. So in this case, even though many people would think that this is a focal seizure, actually it is not. This is not epilepsy. This is, we call it paroxysmal movement disorder. I think you have a course about it, a lecture about it. So in this case, the animal is aware of the environment. It has these contractions of the limbs and has no tonic-clonic movements, no other signs of epilepsy. So this is different from epilepsy. And we treat it, of course, differently. But also for us as neurologists, sometimes it is quite hard to distinguish these episodes, so if it is seizure or movement disorder or something else. So that's why many times we just sit outside and discuss about cases to reach a consensus. So epilepsy affecting the brain is a disease with a great burden, not only to dogs and cats that suffer from epilepsy, but also to humans that suffer from epilepsy. So in people, it can cause psychological, cognitive, and social consequences, and the prevalence is around 6.4 cases per 1,000 people. In dogs, it can lead to impaired quality of life and also impaired quality of life of their owners, decreased life expectancy due to complications, and adverse effects of multiple anti-seizure medications that sometimes we need to use. Behavioral disorders. Many dogs with epilepsy have behavioral disorders like stress, fear, aggression. And the prevalence of epilepsy in hospital populations is between 0.5 to 2.6%, but it can be higher in certain predisposed breeds like border collies. What I want you to remember here is that seizures is just the tip of the iceberg, the tip of the burden. Because what you can see, what we all see is the seizures, but humans and animals with epilepsy have other problems as well, not just the seizures. So the epilepsy will cause seizures, but also will lead to other issues, as we mentioned. So this is just some examples that people with epilepsy have also confusion, depression, dizziness, altered senses, nausea. Dogs can have, as we said, behavioral problems. So those with epilepsy can have aggression and stress. And we need to remember that we should not only treat the epilepsy, not only treat the seizures with anti-seizure medication, but also deal with these behavioral and other problems that the epilepsy will cause. So between human and animals, so human veterinary epileptology, which is the study of epilepsy, have similarities in terms of pathology and semiology of epilepsy, treatment, and quality of life. Therefore, collaboration between physicians and veterinary neurologists is important for exchanging knowledge and expertise and translation of knowledge acquired from humans and rodents to dogs and vice versa. Recently, last year, we published a paper. I was honored to lead this paper, where we gather a panel of experts, human medical doctors, and veterinary neurologists, and we were discussing about epilepsy and how we can benefit from each other. And in this paper, we established a common framework for future translation research in epilepsy. So if you are interested in I think it's worth it to read. So you can see the similarities and differences between human and veterinary epilepsy and what we can gain from them. I would like to mention the International Veterinary Epilepsy Task Force, which is actually the purpose of this force is to develop and disseminate the knowledge about epilepsy in animals, to promote veterinary research and education, and develop care services for animals suffering from epilepsy. This task force has published various consensus statements regarding classification and terminology, diagnosis and treatment of epilepsy. So I would like to mention briefly, when we talk about epilepsy and seizures in general, what we mean. We have the idiopathic epilepsy, which is the epilepsy with or without proven genetic etiology. The structural epilepsy, which is epilepsy due to a brain pathology like a tumor, neoplasia, meningoencephalitis, stroke, or any other pathology in the brain. And we have reactive seizures. This is not epilepsy. We call it reactive seizures because the brain reacts to metabolic causes or intoxications, and this is why seizures occur. There is no pathology in the brain itself, and there is no genetic predisposition. So we have idiopathic epilepsy, structural epilepsy, and reactive seizures. In this study, I would like to mention that the AIDS has an impact on the etiology. As you can see from the diagram, dogs age between like less than 6 months of age, they were suffering either from idiopathic epilepsy or an inflammatory disease like meningoencephalitis of unknown origin, or even a congenital problem like hydrocephalus. Now, dogs between 6 months and 6 years, the gray column, you can see that they were mostly suffering from idiopathic epilepsy. The majority of these cases in this age gap had idiopathic epilepsy, and only a small percentage had other etiology. While the ones that were aged more than 6 years, this is the white column, they were suffering from, some of them were suffering from idiopathic epilepsy, like around 35%, but most of them, they were suffering from structural epilepsy. So as you can see, neoplasia was the most common cause in older dogs. So generally in dogs with epilepsy, we believe that 54% have idiopathic and 45% can have structural epilepsy. These are the prevalences and the role of age, as I said. So in this study, they found that 75% of dogs between half a year to 6 years were suffering from idiopathic epilepsy, and only 3% they were suffering from brain neoplasia. So in dogs more than 6 years, 35% were suffering from idiopathic epilepsy, but 64% from structural epilepsy and mainly neoplasia. So the AIDS has an impact on the etiology, and geriatric cases, geriatric dogs and cats will suffer more likely if they have a seizure onset more than 6 years of age. They will suffer more likely from structural epilepsy, but it can still be idiopathic. So if we talk now about treatment, what could be our treatment goals? First of all, the primary goal would be to eliminate the seizures. So this would be the gold standard, or at least to increase the period between seizures post-treatment more than 3 times compared to pre-treatment. For example, if the dog had 1 seizure every week, if we can have a frequency of 1 seizure every month post-treatment, this is also a treatment success. Secondary goals are to prevent emergency seizures, so cluster seizures and status epilepticus. So if our medication, if our treatment manages to stop clusters and status epilepticus in the dog or cat that had these events before, this is also success. When I talk about cluster seizures, I mean more than 2 seizures per 24 hours. And status epilepticus is non-stop seizure activity lasting more than 5 minutes. Other goals are to reduce the frequency of seizures more than 50% post-treatment compared to pre-treatment, decrease the severity, like the time or even the type. If a dog had generalized seizure before, if we manage to make them focal seizures, that's also kind of a success. And improving the overall quality of life for the dog and the owner. So we need to address the underlying cause. If it's, for example, a structural epilepsy, we need to try to address the meningoencephalitis, the neoplasia. Otherwise, the seizures will not really stop, only with anti-epileptic medication, anti-seizure medication. And the other primary goal is to give anti-seizure treatment, which might work better in dogs with idiopathic epilepsy, just because we don't have any brain pathology affecting the activity of the seizures there. So what are the predictors of treatment in the case of structural epilepsy? So in this study, they found that the most important prognostic factor was the appearance of status epilepticus, so emergency seizure, before the diagnosis. So dogs with status epilepticus had reduced survival time, shorter seizure-free periods after diagnosis, and overall worse seizure control. Dogs with cluster seizures showed similar trends, but there were no statistical significant differences. So if you have a dog aged more than 6 years of age and you highly suspect structural epilepsy, or you diagnose structural epilepsy like a brain tumor, for example, if this dog had status epilepticus before the diagnosis, this is a negative prognostic factor that will tell us that possibly the treatment might not be very effective, the anti-seizure treatment. However, the final treatment outcomes are not significantly affected by the specific etiology of the structural epilepsy. So, for example, if we have a neoplasia or a stroke, without any event of status epilepticus, the treatment outcomes would be possibly similar with regards to controlling the seizures. However, dogs with meningoencephalitis had survived actually longer compared to other pathology, compared to neoplasia. So now let's talk about anti-seizure medication. So we're going to talk about the most common ones. And the most common you use in general practice is the phenobarbital, potassium bromide, imipitoin. Maybe you don't use this medication. I think it's only approved anyway in Europe, but I will mention it. And levetiracetam. Less frequently used are zonisamide. In the States, in North America, they use zonisamide a lot. So you might use it as well. Gabapentin, topiramate, these are other medications. So if I have a dog with, let's say, idiopathic epilepsy, and I want to start treatment, which drug should I start as monotherapy? So as a first-line treatment. phenobarbital or potassium bromide. According to this study, they found that both phenobarbital and bromide were reasonable first choice anti-seizure medications, but phenobarbital was more effective, it was more potent for controlling the seizure frequency. So if you had to choose, possibly would choose phenobarbital over potassium bromide. Now, if you have to choose between phenobarbital or imipitoine, imipitoine is only licensed in dogs with idiopathic epilepsy, while phenobarbital, it can be given also in dogs with idiopathic or structural epilepsy, and in dogs that experiencing emergency seizures like status epilepticus and cluster seizures. So if you have a dog with idiopathic epilepsy and without any events like cluster seizures or status epilepticus, you could give imipitoine. According to this study, they found that both of these medications are effective. However, I have to mention that newer evidence shows that phenobarbital is likely more effective and even more tolerant than can be tolerated better than imipitoine. So if I have to choose again between phenobarbital and imipitoine, if you have a dog with high seizure frequency, you might want to try phenobarbital, as it might be more effective. However, it's not wrong to start imipitoine and see how the dog will respond. Levetiracetam, can I start as monotherapy? Well, actually, levetiracetam is a very effective drug and is one of the safest. The main adverse effects is lethargy and ataxia, actually, which is a very good drug. However, we have the honeymoon effect. So as you know, when you start dating somebody, everything seems so perfect at the beginning, but after a few months, the shadows come, so the honeymoon period passes away. So what's happening with levetiracetam? If you give levetiracetam as continuous therapy, it has been shown that after a few months, after around 6 months, the dog might develop tolerance to the drug, which means that levetiracetam might not be so good anymore, might not be as effective as before. So we prefer not to give levetiracetam as a continuous therapy. So especially in dogs with idiopathic epilepsy. So what about giving levetiracetam as monotherapy in structural epilepsy, where you end up not giving the drug for too long, because if the dog has neoplasia, the survival times are not long anyway. Of course, it depends on the type of tumor and the way that you will treat the tumor. But in these cases, we could try levetiracetam as a monotherapy. So based on this study, they showed that levetiracetam was a promising treatment option with 53% of dogs achieving very good seizure control. And they compare actually the phenobarbital monotherapy with levetiracetam monotherapy in structural epilepsy. So they found that the average seizure-free period in monotherapy with levetiracetam was 140 days, and only 59 in the group with phenobarbital. The survival time for dogs in the group of levetiracetam monotherapy was 542 days against 102 days in the group with phenobarbital. So you can see that actually in dogs with structural epilepsy, the ones that were treated with levetiracetam had better outcomes compared to the ones treated with phenobarbital. However, the results were not statistically significant. The difference was not statistically significant, so we cannot have firm conclusions about this. I guess if you have a dog with idiopathic epilepsy, I would prefer to start phenobarbital. If you have a dog with structural epilepsy, you can choose. You can either start with phenobarbital or even start with levetiracetam. Some years ago, we did this systematic review where we evaluated all the evidence at that time, and we conclude that back then the most effective drugs for treating idiopathic epilepsy was phenobarbital, followed by mepitoin, and then other drugs like potassium bromide, levetiracetam, and so on. Newer evidence shows that phenobarbital is even, as I said, is even more effective than imipitoin, but it's worth trying. Then we did another systematic review and meta-analysis of all the evidence about the safety of the seizure medication, and we found that levetiracetam was the safest drug of all, followed by phenobarbital, and then by potassium bromide. So potassium bromide was not as safe as we thought, and phenobarbital was not as bad as we thought. But the most effective drug was levetiracetam. The safest drug was levetiracetam. Now, let's say you have a dog with idiopathic epilepsy and you start the first medication. However, the dog does not respond very well, or maybe responding quite well, the seizure frequency reduced, but after a while, after a few weeks and months, you manage to measure the levels of the drug. You give the optimal doses of the drug. Like, let's say you started phenobarbital, and you have measured the levels of phenobarbital. They are optimal or the highest possible, the highest normal. The dose is optimal, but the seizures are not well controlled. So what we do then we have to start a second medication. We have to add another medication. So if you have started first with imipitoin, not phenobarbital, imipitoin as a first line, usually imipitoin, the Pexion, we started with 10 milligrams per kilogram. If it's not very effective, we go to 20. And lastly, we go to 30 milligrams per kilogram twice daily. If you try this maximum dose and it is not controlling the seizures, then you need to add a second medication, which is either phenobarbital or potassium bromide. In this study, they found that the seizure frequency reduced. So they had dogs with suffering from idiopathic epilepsy that were on imipitoin, Pexion monotherapy, and they added either phenobarbital or potassium bromide. They found that the decrease in seizure frequency occurred in both groups. However, the phenobarbital group might have a better decrease, but both of them medications could reduce the seizure frequency after the addition. So either they started phenobarbital or potassium bromide, they were both actually effective. Now, if you have started with phenobarbital as a first line, as a monotherapy, as I said, you need to make sure before adding a second medication that you give the optimal dose of phenobarbital. And how you make sure is by measuring the levels, the serum concentration of the drug in the blood. If you have reached optimal or maximum levels and the seizure frequency is not controlled well, then you need to add another medication. And this can be either potassium bromide or imipitoin at these dosages. Remember, if you add potassium bromide, you need to aim for serum concentrations of the potassium bromide between 1,000 and 2,000, more or less. While if it is monotherapy, the potassium bromide, you need to aim up to 3,000. So this is what you need to do after if there is no response to the first medication. Now, imagine then that you have started already 2 medications and still the seizure frequency is not well controlled. So what we need to do then is to try multiple anti-seizure medications. You have to remember that approximately 30% of dogs with idiopathic epilepsy manifest resistance to multiple drug therapy. So if you have already 2 drugs, let's let's add a third one. It can be levetiracetam. However, as I said, I would prefer not to give levetiracetam as a continuous therapy, but if you have no other choice, then we have to, because of the honeymoon effect. Okay, we have to. But if you have another choice, then I would prefer to keep the Keppra as a rescue medication. And what I mean by this is to give the Keppra as a pulse therapy for cluster seizures. So what you can do, you can continue your long-term medication, let's say phenobarbital, potassium bromide, imipitoin, if you give all of them. And then if the dog has cluster seizures, so more than 2 events per 24 hours, what you can do is to add Keppra for a short period, so to stop the cycle of seizures. So you can, after the second seizure per 24 hours, you can start like 40 to 60 milligrams per kilogram, and then every 6 to 8 hours, you can give 20 to 30 milligrams per kilogram. And when the dog reaches a period that is seizure-free for 2 days, then you can stop the Keppra. So you give it for a short period to stop the clusters, to help with the seizure management. And by this, if you don't give it all the time, like every day, if you give it as a pulse therapy, you will not have the honeymoon effect. So the drug will be effective most likely every time. Another thing you can do is to add zonisamide as a continuous medication. Like, let's say you have a dog on phenobarbital, potassium bromide, you can add zonisamide. If the dog is on phenobarbital, the dose of zonisamide should be the maximum, like 10 milligrams per kilogram. It's a relatively safe medication. It can have some adverse effects like lethargy, ataxia, and rarely liver disease, but also it has shown that it might have also the honeymoon effect like levetiracetam if you give it continuously. And then imagine you give 3 medications and there is no response. Then the answer you will get possibly is this. But maybe we are not, because there are other options you can try, which might be in a more specialty level, that might help with the seizure control in drug-resistant cases. These can be clinical diets, surgery, or brain stimulation. Diet is a measurement that you can implement in general practice and everywhere, and it's very easy. And actually, you don't have to wait to implement this measure until the dog is drug resistant, or you don't have to wait to see if the dog is drug resistant to start specific diet. You can start the diet from the very, very beginning if you suspect idiopathic epilepsy, because this can control better the seizures. And also, if it controls better the seizures, you might not need to add a lot of medication at higher doses. So diet is something that I would definitely recommend to start from the beginning in idiopathic epilepsy management. And when we talk about diet, mainly we talk about ketones and medium chain triglycerides. So medium chain fatty acids. So in humans, they were popular at times. They have been tested actually since 1920. They became less popular after using anti-seizure medications, but they are again to the front. They have relatively good effect on children with epilepsy, but also in adults, I would say. To the dog, there are relatively recent studies supporting the anti-seizure activity of ketogenic diets or diets with MCTs. So the clinical diets in dogs, they showed they showed very good results. They found that it is safe and effective. And as I said earlier, it can help in using the anti-seizure medication better. So lower doses, less medication, because the seizures will be controlled also with the diet. So mechanism of action is not fully known, but we don't believe that it's only because of the production of ketones. The MCTs can actually enter the blood-brain barrier in contrast to the long-chain fatty acids, and can be directly oxidized in the brain. So by this, they offer an alternative and direct source of energy to the brain, because the energy and the glucose metabolism in the epileptic brain is defected. So these MCTs, they offer another source of energy, which is good for the brain. And also they cause some changes in lipid metabolism, and they have an effect on the brain neurotransmitters. In rats and dogs, the diet with MCTs showed that could increase mitochondrial mode, brain energy reserves, and the metabolic composition of PUFA and their recruitment from the brain. So all this shows that the brain could utilize these fatty acids and can use them as energy. It can affect its transmission. So all this could affect actually the epilepsy, could reduce the seizure frequency. And as we said, we believe that they have multiple effects. Some of them might not be known. For example, the decanoic acids, they can act as non-competitive antagonists of the MMPA receptors. These are excitatory receptors. So if you antagonize these receptors, you're gonna reduce the excitation. So it will not favor the seizure activity, because seizure activity is favored by excitation. So if you block the excitation, you can also reduce the seizure frequency. Effects on pediatric cases in humans, they found that half of them have 50% reduction in seizure frequency, and a quarter 90% reduction, and actually 1/5 100% reduction, and the response was immediate within 2 weeks. In dogs, they have done some trials based on this double-blind randomized crossover clinical trial. Dogs fed with a diet with MCTs for 90 days, and they showed the reduction in seizure frequency compared to the control diet. 71% experienced a reduced seizure frequency. So 48% of them had more than 50% reduction in seizure frequency, and 14% of them achieved the seizure freedom. In another study, they compare the diets of MCT with another diet where they added control oil, which was the olive oil. They found actually similar responses to the previous trial. So in the group with the MCT, 71% experienced reduced seizure frequency, 18 of them more than 50%, and 14 seizure freedom. And this was significant compared to the olive oil. So MCTs could reduce the seizure frequency compared to olive oil. So what about omega-3 fatty acids? Many people think that, yeah, if we add omega-3 fatty acids, they might be also effective. Well, we don't have enough evidence to say about it, but we have some degree of evidence. So one case report showed possibly beneficial action. However, in a better study, in a blind randomized placebo-controlled trial, no effect was shown. So based on the current evidence, omega-3 fatty acids might not have anti-seizure effect, but we might need more studies on this. Gut-brain axis. So how the brain is affected by the gut microbe and vice versa. So this is a very hot research topic in both humans but also in animals. So the microbe in the intestines plays a key role in the pathogenesis and development of various neurodegenerative disorders like Parkinson's and Alzheimer's, schizophrenia, autism, and multiple sclerosis. So these diseases can affect the composition and function of the microbe through some gastrointestinal inflammation and dysfunction. So the involvement of the microbe in pathogenesis has been shown recently based on data from people. What's happening, the intestinal microbe and actually is different, alters in humans with epilepsy. So humans with epilepsy have different microbe compared to healthy humans. This can lead to differentiation of intestinal permeability, alteration of local immune response, and changes in the production of various metabolites and neurotransmitters. This can also affect the epilepsy. It can affect the brain, the function of the brain, and vice versa, the function of the intestines. So more research is needed, but is a topic that might help. So if you change the microbiome in the intestines, you might help controlling the seizure frequency better. You might help controlling epilepsy. Surgery, I'm not gonna stay much on this. It's still in immature stages in animals, because you need advanced neuroimaging techniques like combination of functional MRI and electroencephalography, magnetoencephalography to detect the epileptogenic zone, so the zone that produces the seizures, and then remove it surgically. So still in immature stage, but we might have more evidence in the future. About neurostimulation, I would like to mention some principles because it's something that you might have access to, or you might need to refer to a specialist to do it if they have the equipment. So the electrical and magnetic stimulation, it can affect the function of the cerebral hemispheres, either immediately, like intracranially, or indirectly, extracranially. So there are a few methods, but the main ones is the vagus nerve stimulation, the deep brain stimulation. So the vagus nerve stimulation is indirect because you stimulate the vagus nerve, and then if you stimulate the vagus nerve, it will affect the brain. The deep brain stimulation is invasive and is direct because you have to do surgery and to implement an implant inside the brain to stimulate the brain. And we have the repetitive transcranial magnetic stimulation. This is direct brain stimulation, but non-invasive. So we're going to talk about this in a bit. So with the vagus nerve stimulation trials in dogs and humans, they saw that it is effective, and actually its effectiveness gradually increases over time. I'm not going to go into much details on this. It requires surgical procedure, and yes, it can be effective in drug-resistant cases. Now, I will talk a little bit about the transcranial magnetic stimulation because it is a method that is non-invasive. It doesn't require surgery, and it is used in humans on various disorders. If you have access in such a stimulator, it might help dogs with epilepsy. So it uses actually magnetic fields to cause an electrical stimulation in the brain. So it is based on the Faraday's law of electromagnetic induction. If you remember possibly from school, if you have a coil, a metallic coil, and there is electric current going through this coil then will generate a secondary magnetic field. In magnetic stimulation, this focused magnetic field will affect the brain if you put the coil directly on the vertex above the skull. So this is also what I am doing. I treat cases with drug-resistant epilepsy using transcranial magnetic stimulation. This is actually our setup. We have the dogs on sedation, on CRI of dexmedetomidine to keep them sedated, not general anesthesia, so sedation and oxygen. Otherwise, they will not stay there to stimulate their brains. In the middle, you can see the electrophysiological machine. So this is the electromyography, and I use this machine to monitor the contractions of the muscles, because when you stimulate the brain, you should see action potentials in the muscles. So we use needles while the dog is sedated on the muscles, on the limbs. So once you stimulate the brain, you can see the contraction. So this means that you actually stimulate the brain. And on the far left is the actual stimulator. This was this is in Germany, what I'm doing there. But when I was in Ghent, in Belgium, we published the first study in intracranial magnetic stimulation in dogs with epilepsy, with drug-resistant epilepsy. This was the first study. Now we're applying with a better machine in other cases in Hanover. And I would like to show a brief video. So this is how we stimulate the brain with a coil. You see, it's non-invasive. We just put it on the vertex on the skull, and these magnetic fields will stimulate the brain. If you stimulate the brain, you will see recordings on the electromyography. These are the action potentials on the muscles. So this is what we see there, meaning that we stimulate the brain. And this is actually the magnetic stimulation, the machine that we use to stimulate the brain. So this is the setup. It might look a bit complicated, but actually it's not. And of course, is non-invasive. So if there is access, it might worth trying in dogs with drug-resistant epilepsy. So they use it in humans, also in epilepsy, but actually it's FDA approved for the treatment of depression and neuropathic pain that is resistant to drugs. So they use it as an FDA approved treatment in these cases, and there are many trials on epilepsy. But you see, of course, in humans, all these companies, they always show images of people like being very happy and smiley, which is actually a little bit peculiar because, okay, it's not a painful procedure, but I don't know how you can smile so well and be so happy while somebody stimulates your brain, but this is how they promote it. So I just want to mention the results from the first study we did. So we found that the frequency of the seizure was significantly reduced in the group with the active stimulation because we have the active and the placebo stimulation, the sham stimulation, so non-active. So you could compare to see if the active is effective or not. So we found that there was a statistically significant reduction of seizure frequency in the active group in the dogs treated with active stimulation, so pre to post stimulation. So the seizure frequency reduced. This was not detected in the placebo group, but the overall stimulation lasted for the overall effect lasted for 4 to 6 months. After this period, the seizure frequency started increasing again. So we assume that this is a method you need to repeat over time, depending on how long it lasts. So if you do a stimulation in a dog, if it lasts for 4 months, and then the seizure frequency starts increasing again, then you need to repeat it. So, and the technique was quite safe, yes, as an adjunctive therapy in dogs with drug-resistant epilepsy. So I'm nearly finishing now. I just want to mention very briefly the take-home messages. So your first-line treatments are the anti-seizure medication. You need to try sometimes more than one to make sure that you can control the seizures. So the selection of the appropriate medication will be based on the effectiveness. As we mentioned, that some anti-seizure medication are more effective than others, like phenobarbital is likely the most effective in veterinary medicine. The adverse effects, now if you have a dog with liver disease, you cannot start phenobarbital because it will metabolize in the liver. So in that case, you need to start potassium bromide. Also, you need to consider levetiracetam because it's quite safe drug. So in dogs or cats that have severe systemic diseases, maybe you need to consider a drug that it might not be as effective, but it might be safer. As I said, the animal's health, the frequency and ease of administration of the drug. So, for example, the levetiracetam you need to give 3 times daily, while other drugs like phenobarbital you need to give 2 times daily. So some owners don't want to give 3 times daily, so we opt for twice daily medication. And the cost. For example, phenobarbital, at least in Europe, is quite cheap, while levetiracetam, well, Keppra is quite expensive, while levetiracetam is less expensive than generic drug, but still more expensive than phenobarbital. And remember that if you diagnose dogs with idiopathic epilepsy, around 30%, 30-35% will manifest drug resistance. So then you need to add other non-pharmacological option, as we said, or to refer for another treatment. And remember that it's worthy always to start diet even from the beginning when you diagnose idiopathic epilepsy, because this might help with your management. Thank you so much for your attention.
Okay, doctor, thank you very much. It was a great talk. We really appreciate it. We have a few questions. So I'm going to tell you now.
Yeah.
The first one is about the diet. Is how much MCTs do I have to add in the diet of the patient? Can I use it in cats too?
That's a good question. So I cannot give a precise dose because it's not like we add MCT. Even if you want to add MCT oil, there is the studies that have been done up to now. They didn't just add the MCT like this. They implemented in already clinical diet. So what I would recommend is to give the clinical diets that they have already established MCT inside, because they have their perfect ratio. If you add MCT on your own, this might not be effective, or it might cause even side effects like gastrointestinal problems. So it's better to buy the clinical diets. There are some clinical diets like Purina NeuroCare or some others that can have like the perfect ratio and everything. So all the ingredients that the dog needs, actually. So you can only feed the dog with this diet.
Okay.
There was another question on that.
Yeah, but you answer it in the same answer. But there is another question about other therapies. If you have experience with acupuncture and other options.
Well, you could try acupuncture. However, we don't have enough evidence to say or to claim that it is effective in drug-resistant epilepsy. There are some like minor reports or anecdotal experience that yes, it might help, but I don't have enough scientific evidence to claim that it will help. I mean, you could try if you are in a desperate situation and nothing works. Yes, you could try.
Okay. Okay, perfect. There are a few questions that you can answer or not, because Dr. Marios is going to give also the lecture about status epilepticus in June. So one is about the benzodiazepines via intranasal or intrarectal, and the other one about the coma, barbituric coma or propofol. If you
Uh,
want, we just
shall I answer now, or we
as
will
you
cover
want, as you
this?
wish.
But I can answer. So the first question is about giving intranasal benzodiazepines, right?
Yes,
So
or intrarectal.
if you want to give intranasal benzodiazepines, you should choose midazolam, or if you don't have midazolam, you can even give intranasal diazepam. But we have evidence studies that I have done that show that intranasal midazolam is quite effective and even more effective than rectal diazepam. So yes, intranasally you can give midazolam and to a less extent diazepam. Rectally, if you want to give rectally, it might not be as effective as intranasal, but you can still give, and you can give diazepam. Don't give rectal midazolam because it will not, because the pharmacokinetics are not good for midazolam when it's given rectally.
Okay. Okay, perfect. And the other one is in which cases you will consider to put under anesthesia or barbituric coma to a patient?
Well, I guess, yeah, in status epilepticus, well, we're gonna cover this a lot in the other presentation, but I can briefly mention that this is a third line. So if you have reached a stage of status epilepticus and is not responding to the other medication, like if you give first benzodiazepines, then you add phenobarbital levetiracetam, there is no response. You add, I would add first ketamine, CRI plus minus dexmedetomidine. And if you reach that stage and the dog does not respond to all this, then you can go for general anesthesia with propofol. It's not wrong to start propofol earlier before ketamine, but we would recommend to start propofol like general anesthesia after ketamine, also because of safety reasons. But we will cover also this in the other lecture.
Okay. And also there is the new paper that you released.
The consensus, yes.
There is another question of a doctor, I think, from Argentina, that is saying that he's having trouble to get potassium bromide, and also in Argentina there's not imipetoin. So what's the option there if the phenobarbital is not responding? And there is another part of that question that it says what is the dose of levetiracetam if you use it with phenobarbital?
Okay, so if you have phenobarbital potassium bromide, then they don't have potassium bromide, they said, right?
He's having trouble
Okay,
to get it. He
so
asked
then
also about cannabis or pregabalin.
So in that case, I would add either zonisamide, if they can get it, on the higher dose, or even levetiracetam. Of course, we said that levetiracetam is better to avoid as a long-term, or like
Yeah.
continuous treatment because of the honeymoon. But yes, if they don't have other option, you can add levetiracetam, and yeah, or zonisamide. Yeah, gabapentin and pregabalin, like gabapentin, are other options also. We don't have enough evidence to say that they're very effective anti-seizure medications, but it can be another option like gabapentin to add in these cases.
Okay.
Levetiracetam can be given in the dose between 20 to 60 milligrams per kilogram. Even if you give phenobarbital, you can still give a higher dose, even though some people prefer to give lower dose if you give already phenobarbital. But the range is a quite safe drug, and I would say that if you really have hard time to control the seizures, don't be afraid to give higher dose of levetiracetam.
Okay.
And the CBD is the last, the cannabis, right?
Yeah, about the use of CBD, if you use it or if you have experience.
Yeah, well, there are a few studies that they evaluate the CBD. Well, I haven't used it myself in any case, but I cannot claim for sure if it is effective or not. We don't have like enough evidence, but again, I wouldn't say no. I mean, you could try and see. Maybe it will help in dogs that are drug resistant, for example. Yes.
Okay. Um, yeah, no, the dog is asking about the when he asked about the levetiracetam because he said that he read that the levetiracetam should use it in higher dose when you use it with phenobarbital.
That's correct. That's correct. This is because the metabolism of levetiracetam is affected by phenobarbital. So yes, you can use it in higher doses, but of course you need to to evaluate, I mean, if the dog is already very sedated and ataxic because of side effects, if you give very high dose of levetiracetam, you're gonna accelerate the sedation ataxia. So in general, yes, with phenobarbital, we prefer a higher dose, but you need to assess. You can start with a lower dose and then see if the dog responds, and then go to the higher dose. So I think up to
Okay.
60 milligrams per kilogram can be given.
Okay. And I think the last question is about if you have experience with lamotrigine.
I don't have experience with this medication. I'm not sure there are really there is a lot of evidence about this. Because we need to do trials on this, it might be that this toxic for or it has there is a safety issue with this medication on animals. So I wouldn't give something that is not very well studied.
Okay. Okay, perfect. I think that's all. So thank you very much. We see you in your next conference.
Thank you.
Okay. Oh,
Oh,
my
and the
cat.
cat just appears to say hi.
Okay. Thank you very much. Good night, doctor.
Thank you. Good night. Thank you.
Bueno, la próxima conferencia va a ser el día 1 de abril, que va a ser sobre desórdenes del movimiento, diagnóstico y tratamiento, que lo vamos a tener de nuevo el doctor Paul Mandigers. Buenas noches a todos.